Welcome to Doctors on Call. Tonight we're answering your questions about upper gastrointestinal problems. So call in questions for indigestion, heartburn, ulcers, gallstones, liver and pancreatic diseases. I'm your host, Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm pleased to welcome our medical panelists. Dr. Robert Erickson, a gastroenterologist with Essentia Health, Duluth Clinic, Dr. Mary Owen, a family medicine physician at the East Lake Clinic, Mille Band of Ojibwe, and faculty member at the University of Minnesota Medical School, Duluth, and Dr. Chris Thiessen, a family medicine physician at the Gateway Family Health Clinic in Moose Lake. We'll be happy to take your questions. Just please call in locally at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering the phones tonight are all from Minnesota. David Jonathan hails from Detroit Lakes, Seth Nelson is from Spicer, and Matt Peterson is from Alexandria. And now on to tonight's program. So I think we'll just start with a procedure question first while we're waiting for some questions. Dr. Erickson, can you tell us, like EGD, we hear that term and people don't know what it is.
Well, EGD is short for esophageal gastroduodenoscopy. That's a long word, but basically we're inspecting the esophagus and stomach and first part of the small intestine or duodenum. And generally patients come in after eating nothing after midnight, so their stomach is empty because we can't see through food. And they get sedation. Some patients require more sedation, some less, and they're lying on their left side, and we take a look down, and we can get some biopsies, advancing small cables through the instrument, which are sent to our pathologist to take a look at. And it's been quite an advancement in diagnosis of upper gastrointestinal disease over the past 40 years, I'd say.
Excellent. Well, Dr. Owen, so if somebody came in with chest pain, would we think about upper GI problems?
Absolutely. One of the things, common causes probably is reflux for some of those symptoms of chest pain, and we have to make sure that that's not the cause. Actually, you rule out the cardiac, the more serious first, but one of the things that in the background is the not just reflux disease where food can come up, the stomach contents can come up into the esophagus and cause some burning, but it also can cause some spasm of the esophagus, which can cause some chest pain.
Well, and Dr. Thiessen, people complain about, hard time swallowing, like dysphasia. That might be a term we would use.
Yeah.
Describe that for us, and what would be a common problem related to that?
Well, people can have trouble with that starting from the back of the throat and the mouth. We have some people where acid can make that burn, or as they get older, they can lose some coordination in the back of the throat. And you might notice somebody coughing or choking as they eat or drink. And we want to have you pay attention to whether that's with thin liquids like water or whether that's with food. You can also have problems with swallowing that start part of the way down. You can get muscle spasm in the esophagus, the tube that the food travels through down to the stomach. And that can feel like you swallow and then get kind of a crushing pressure in the chest, and then it might relieve and go down. And we also have some people that get muscle spasm at the bottom of the esophagus that doesn't allow food to go through very well. So they'll start swallowing and they'll fill it up, and they won't necessarily have pain, but they'll feel very full, and it takes a while for the food to get down.
So is there anything we can do about that, Dr. Erickson?
Oh, there is. If it's a structural problem in the esophagus, such as a ring from heartburn, literally burning a ring in the esophagus, we can go down and dilate. Of course, the concern is, especially if there's weight loss or warning symptoms of esophagus cancer, or some older patient, maybe smoking or high risk factors for esophagus cancer, that warrants an endoscopy to take a look down. There are motility problems of the esophagus. The esophagus moves food through like a tube of toothpaste, if you would, contracting things down. A lot of times that's related to acid reflux, as Dr. Owen mentioned, irritating the esophagus, and we can treat that with medications.
So I have some calls coming in now. Dr. Owen, there's a caller from Superior, so asking about fatty liver disease. What would be the cause of fatty liver disease and any treatment options?
Treatment options. Well, fatty liver disease is an accumulation of fat, basically, that builds up in the liver, and it can actually even cause a form of hepatitis from the inflammation. But treatment, of course, is going to be geared at weight loss, unless you know of some other treatments that I'm unaware of.
No, that's really the hallmark is weight loss. They've looked at other things, but it really is weight loss. And it gets down to sometimes it's a warning of what's called the metabolic syndrome.
Right.
So people have diabetes and hypertension, hyperlipidemia. So we see young people with this and we say, you go along another 10 years and all these problems can really build up. So sometimes it's just a harbinger of things to come.
And we're seeing younger and younger people now with fatty
Exactly,
liver
you know,
disease.
and a lot of it is related to high carbohydrate food, high sugar food that people are consuming, and alcohol is a high risk factor for fatty liver.
Which is a little bit frustrating because for so long people were told that carbohydrates were better to eat than the high fat foods or the meats, and now
Type
we're
of
realizing-
carbohydrates, the sugars, I think, is
Right.
probably really contributing.
True. Yeah.
Well, Dr. Thiessen, a caller from Duluth asking about an ulcer. What type of symptoms would I have if I had an ulcer?
Well, the timing of the symptoms might help you tell a little bit about it. Sometimes if you have an ulcer, when you have an empty stomach and the stomach acid is in there without any food, you might feel more pain because it's burning into the ulcer. You don't want it to get worse where you might have bleeding or even diarrhea with blood. And you might notice that food would make it a little better. And people will often try over-the-counter antacids and get some relief. You want to watch out and speak to a physician to make sure that that isn't a sign of stomach cancer or something else as well. So it's okay to start with the antacid treatment, but you should probably see somebody and make sure that they can take a look.
And they might test for H. pylori.
Yeah, I have a caller asking about H. pylori. Talk about that a little bit more.
So H. pylori is Helicobacter pylori. It's a bacteria that is very common actually in 50% of the population. It tends to hit more socioeconomically deprived areas than others, and by that nature probably affect more people of color. It's a bacteria that can be treated. We don't, usually you check though before you treat it, like even if someone has an ulcer, because not everybody with an ulcer has H. pylori. The treatment is usually 2 antibiotics and a proton pump inhibitor, but you have to be evaluated for it first.
And with H. pylori, I was wondering how good are the stool tests for that? Because as a family physician, that's a very convenient way for us to take a look at it.
Well, you know, the literature stool test is supposed to be 90% accurate, 80 to 90%. I think it's good first try, you know,
Yeah.
and if that's negative, they still have symptoms and probably warrants taking a look, like you had mentioned.
Absolutely.
More warning symptoms could be other things.
Yeah.
And breath tests as well.
The breath test is out there. We don't do it too much anymore. You know, haven't done one for a while, but that's where they consume a liquid and the bacteria degrades the liquid and they blow out the gas. But yeah, we haven't done that for a while, but it is another way.
And how soon can you treat after if you've treated somebody, how soon can you re-examine them to see if they have it, or would you?
I usually wouldn't,
Okay.
you know, unless they have symptoms.
So let's switch topics. That was great. How about Barrett's esophagus? You want to talk about that a little bit, Dr. Erickson?
So Dr. Westra, Barrett's esophagus, and to the viewer who called that in, is after many years of acid reflux, intestinal-like tissue coats the esophagus, trying to protect the esophagus, if you would. That's the way I think about it. And it has a higher risk of esophagus cancer in those patients who have it. It's the very minority that get esophagus cancer, but if you want to find esophagus cancer, you want to find it early because the esophagus is very, very thin. So we do screen patients, and we were talking about this before the show, especially males, overweight, at high risk with a lot of heartburn. We'll screen for Barrett's esophagus if they've had heartburn. If they do have that, then they go on a surveillance program. If we do find early unusual cells called dysplasia, then we can go down and treat on the surface. In the past, patients with high-grade unusual cells had a portion of their esophagus removed, but now we can treat on the surface, and it's much less invasive, of course.
And you do it like through the scope?
Through the scope,
EGD.
exactly.
Yeah,
And what's the
excellent.
treatment? How do you treat?
It's called radiofrequency ablation, so it's kind of ablating it on the surface. Very effective.
So Dr. Thiessen, a caller from Duluth asking about hiatal hernia.
Oh.
So what causes a hiatal hernia and any ways you can prevent symptoms related to that?
So your stomach is supposed to stay below your diaphragm, and the diaphragm is the muscle that cuts across the bottom of the ribs, and when you breathe, you pull that muscle down and the lungs expand. But there has to be a hole in there for the esophagus to go through, And sometimes that hole has enough space that the stomach can actually squeeze up into the chest and give you cramping or stomach acid. And that's one of the things that can make people have discomfort or chest pain or upper part of the stomach pain. Once you have that, sometimes it helps to take a stomach acid medicine. Sometimes people go to surgery to try and cut that or sew that together so that there's not as much of a space.
Good, thank you. So Dr. Erickson, several questions about Nexium, PPIs. Works well, but why don't we take it long term? We can all probably contribute to this one.
We were just talking about this with medical students before. Nexium and Prilosec and the PPIs, they, when I first came out of practice, they were with a black box warning because they reportedly caused this carcinoid tumor in rats, but that was not the case. So then we went on decades without a lot of side effects associated with PPI. We didn't, but now they've really come in these past 8 years really, and some of them are low magnesium, development of Clostridium difficile diarrhea when you're on antibiotics, and the new ones that come out that have really scared people are kidney disease and dementia. And the dementia is an association. It hasn't been shown to be true cause and effect, but it was a JAMA paper with 76,000 people that they looked at in between 2004 and 2011, or 2011, and the incidence of dementia was higher in that population. So it's not they haven't proven the cause and effect, but they believe it's there. So we try to get people off of those agents now because of that.
Do you ever start them? Sorry.
I do, when people have a lot of esophagitis, a lot of symptoms, but I think as physicians and as patients, being your own advocate, to ask your doctor to say, can we potentially look at something else? Sometimes you try something else and the symptoms come back, but you've tried, and I do think that it's worth a try getting off those agents now.
Great. So Dr. Owen, what are symptoms of esophageal cancer? This is a caller from Duluth. Can you help with that one?
Well, it depends on where it is. Again, if you might have those feelings of dysphagia or feeling like something stuck in your throat. The most common ones that we'll ask for when people come in, the ones that might trigger it for us is if there's weight loss, people don't have appetite, if they're having night sweats. I guess maybe spitting up some blood. Is that a possibility?
But also, I think some of the people that I've had have had a very striking change in taste, where they'd put food in their mouth, it wouldn't taste correct, they weren't able to eat and started losing weight as a part of that.
And anemia would be enough.
Okay.
Would be enough.
Any relationship like to drinking alcohol or smoking with esophageal cancer? Is there any relationship with that?
Both of those affect gastric cancer in general.
And esophagus cancer too.
Okay.
Yeah.
Yeah. And obesity.
Also,
Obesity affects all types of cancer, and esophagus cancer is one of them.
and if I'm remembering correctly, very hot teas will also give esophageal cancer.
So Dr. Thiessen, another caller from ESCO asking about, so we're going to talk a little bit about celiac or gluten-free diet. Once you've been started on that, do you need to stay on that forever?
That depends. There are some people where their symptoms are so bad that they would definitely want to stay off of gluten forever. Other people might have rashes or anemia or other medical problems that come from celiac disease. But we also have some people that just feel better without gluten. And for them, if they decide to have a meal with gluten, that's not a critical thing. They might decide later that they paid for it because they don't feel as well. But it's difficult to know unless you know the person themselves. One person, it might be very severe, and for other people, it might not.
Any other additions about diet for that?
If there is proven celiac disease, or if it's biopsy proven, then those patients do need to stay on a gluten-free diet because in higher risk of lymphoma and other risk factors, osteoporosis. So yeah, it is pretty essential. But as Dr. Thiessen was knowing, there's patients that are gluten intolerant. We may not diagnose celiac, but they're intolerant and they feel better, and that's okay too if they continue on that diet.
So we're going to stay on diet a little bit longer. Dr. Owen, a caller from Grand Marais asking about food allergies that provoke upper GI problems. Is that possible?
Specific upper GI problems, I guess I'd have to defer.
Well, there's the true food allergies, the nuts and the shellfish. Those are the true allergies where you actually can get edema.
Right.
The one thing that we are seeing these days, you probably heard of this, eosinophilic esophagitis,
Yes.
which in itself is kind of an epidemic in my career. I don't think we saw it early, but we're seeing it now, and it's being exposed to these antigens. There's usually young males that come in, problem swallowing, often in the middle of the night with a food bolus obstruction. And it's their typical endoscopic appearance, and you biopsy, there's eosinophils or allergy cells in the lining of the esophagus. And we do have those patients looked at by the allergists to see what potential foods.
Are they the typical triggers like peanuts? And
Yeah, it's usually
Okay.
the nuts and the wheat and some other things,
Okay.
shellfish.
So let's switch and talk about gallstones. I've got several questions about gallstones, and wondering, so Dr. Thiessen, I'll give this one back to you, if there's any dietary modifications or anything to do that you can avoid having surgery because you have gallstones.
That one's tough. They've tried different bile salts to help dissolve gallstones. And one of the problems is as the gallstones get smaller, they might actually push out of the gallbladder and cause trouble on the way out. I don't know of anything else.
No, exactly. There's the bile salts have been tried, and it's very limited cases that you can use it. They have to have very small flakes that aren't calcified, and yeah.
And we're fortunate now that we have laparoscopic procedures with the cholecystectomies, a lot less lost time from work, and surgery recuperation is a lot better. So, Dr. Owen, a caller from Duluth, asking about gas and heartburn. I guess we should get there. Any best treatment for gas or heartburn?
The heartburn is fairly easy because, well, even with gas, there are certain foods, avoid the foods that cause them is the most common answer. But certain foods we know are more likely to cause heartburn, like acids, coffee, chocolate. The other typical things that we often tell patients is don't eat just before you lie down. And if you do lie down in bed, some people have better relief by having their bed elevated slightly. I don't know if that's still a common recommendation. I guess those are the ones that I'm most familiar with. Other than gas, there's some gas X or Beano that some people like to use when they eat a lot of beans. That might help. Mainly watching the foods that.
Watch what you eat.
Yeah, but there's a natural increase in the symptoms with aging in general. So as time goes on.
Dr. Erickson, a caller asking about Nash and if it's hereditary.
I think people who have fatty liver, I do believe there's a propensity in the family, but the thing about Nash is that it's just like fatty liver, except it's an inflamed fatty liver. And 15% of the patients with fatty liver can get cirrhosis. So you need to take it serious when you do find out that you have fatty liver. And again, it's that metabolic syndrome, the hypertension, hyperlipidemia, and higher cardiac risk factors, that it's a real eye-opener for folks, that they really need to watch their diet and work with their doctors on weight loss.
Dr. Thiessen, we're going to switch gears again. Hepatitis C. How would I know if I had hepatitis C?
Well, I think the problem is most people don't. And so when we as physicians see somebody for a physical, we might do a hepatitis C test, or we might do other tests for other problems that would show irritation in the liver. And if you have some irritation in the liver, we would want to follow up and see if that's from fatty liver disease or from hepatitis C, which is a virus that can infect the liver. You might not have symptoms for many years, but you might slowly go towards cirrhosis.
There is a recommendation, too, for all people of baby boomer age to get checked for hepatitis C. I don't know.
65 and up.
Yeah. Is that being practiced in primary circles?
It is in my clinic. I'm not sure. I believe it's pretty standard.
We're talking about
what
it.
age
Yeah.
is it's
1965. Anybody born 65? Yeah.
So, Dr. Thiessen, I'll go back to you again. Effects of alcohol on the upper GI. Does it make it better, worse?
It's usually pretty rough on the upper GI. So it can start with being irritating to the lining of the esophagus and to the stomach. But then also it can be irritating to the pancreas that we were talking about, and also to the liver.
How about the effects of tobacco, Dr. Owen?
Well, that's a little bit of a tricky question. In general, tobacco causes all kinds of cancers. But when you look at me, I have to remember to recognize that there's a difference between traditional use of tobacco and then the tobacco that is sold now. And so the tobacco that's consumed constantly that we see everywhere is the source of so many different cancers, including gastric cancer. So for that reason, I would recommend highly against that. But that's not the same to be said for the traditional forms of tobacco use.
Yeah, thank you.
But as long as we're talking about things that we consume, I believe coffee has been shown to be okay and even good for liver disease.
It's always controversial. Once I said pancreatic cancer there for a while. And so, I mean, it goes back and forth.
Mm-hmm.
So we have the coffee and then we have the hot tea to avoid. So, well, Dr. Erickson, talk a little bit more about the alternatives to taking the PPIs. We talked a little bit about that, but I'm getting lots of questions about
Well, that's a good question. And like Dr. Owen said, I mean, you got to go back to the basics of watching your diet, coffee, tea, alcohol, cola, spicy food, greasy food. Don't eat at night. Don't lay down after you eat. Sometimes some people can get by with just some antacids every now and then. And then as you go up, then you get into the class called the H2 blockers. So those were out in the 70s, cimetidine, ranitidine, famotidine. You can buy them over the counter, or you can work with your doctor. But sometimes you just need to heal the inflammation with the PPIs and then go back down to the H2 blockers is another tack too. But again, it's important, I think, talk to the doctor, see what the options are.
And what about like Tums or the over-the-counter chewable tablets we have?
Tums every now and then is fine, if that's all you need. The least, just like everything in medicine and all these other parts of medicine, the least amount of medications that's effective, I think, is the best.
Excellent. So what about so I have a caller, Dr. Thiessen, we talked a little bit about that stomach valve kind of sensation or whatever, manometry. How would you do that, or what are we doing that for?
So there are a couple tests that you can do to try and find if people have spasm in their esophagus. And one of them is to thread a catheter down and measure the pressure in there. You can also do that where you can measure the acid over a period of time. And then sometimes people will actually drink a barium shake and have an X-ray video of their esophagus to see what it's doing while the muscle contracts.
Good. So Dr. Owen, asking about aspirin. So we want people to take aspirin for heart disease, but what are the problems with stomach with the use of aspirin?
Well, acid can cause gastric ulcers, so we're always, the debate in our guidelines is constantly going back and forth, is the benefit, does it outweigh the risk, or does risk outweigh the benefit? And so when our guidelines are changing, that's usually the question, is it worth it for this group of people? For instance, in elderly folks, we're starting to realize the consequences of aspirin use can be catastrophic. We can cause gastrointestinal bleeding from it. Do you see a lot of that, or? We
do, see ulcers in patients, even a baby aspirin a day. So talk to the doctor about ways to prevent the ulcer. Do you want to co-administrate an acid blocking medication to reduce that risk, or should you be taking it?
Right, and or how about NSAIDs? So same issues, concerns. So like, ibuprofen or any of those other meds.
Yeah, I think the issue with aspirin is that they are, as you said, they're so commonly used in our, for cardiac disease, whereas you don't have that question as much with NSAIDs or ibuprofen or naproxen. People don't use them as a preventative medication or a treatment.
But we still see people with arthritis using NSAIDs like ibuprofen or Aleve, naproxen, and we do see that can be irritating to the stomach for some people.
So if people have scopes or are found to have problems, do we rescope the patient once they've had
Depends
a
on where the
GI
ulcer
bleed?
is. If it's a stomach ulcer, we do rescope those because a small percentage can be gastric cancer. But if they are NSAID related, we do encourage them to talk. Some people with arthritis need the anti-inflammatory effect. Again, there are co-administration of some medications that reduce the ulcer effect, or other medications that don't cause ulcers that can treat their pain. So there's, discuss with your provider, your physician, the options of therapy.
Excellent. Well, our time is up. We had lots of questions, so thank you. I want to thank our panelists, Dr. Robert Erickson and Dr. Mary Owen and Dr. Chris Thiessen, and our medical student volunteers, David Jonathan, Seth Nelson, and Matt Peterson. You won't find us here next Thursday due to Thanksgiving holiday, and we'll be off the following week because of Pledge Week here at the station. But we look forward to having you come back on Thursday, December 8th, when we'll be talking about lower GI problems. Thank you for watching. Good night.